here we go. So we are going to talk about the correlation between early infantile chest wall surgeries and the risk of scoliosis later on in life. This has been a topic of fascination for me for about 10 years. Our story began with one of my very dear colleagues who was doing some scoliosis training. He was on the fabrication side of things. He's like, oh, yeah, you see an x-ray with a wire on it, and you know it's going to be an awful case. It's going to progress. It's going to be an awful, awful case. A different colleague would go, nah, that guy's full of it. Those kids are just fine. They're no different from anyone else. I'd go on PubMed, I try to figure out what's going on, and I see that, the data supports both of them. I did have a very, very dear colleague join our team about 8 years ago. Uh, she kind of blew my spine skills out of the water and became our spine geek. I became the extremity geek. And as luck would have it, we had a patient who did have a chest wall surgery in infancy. And he comes in and the curve doesn't look typical and the progression doesn't look typical. So it became game on. Let's study this. Let's see where it stands. So first thing we try to do is we try to do a meta-analysis. Go on PubMed, identify some diagnoses that lead to these corrections early in infancy, and see how many of them would have scoliosis or reported to have scoliosis in adolescence or later on in life. We came up with 13 studies, and there was a very clear positive correlation. 10 of the studies reported a significantly increased risk of scoliosis, 3 did not. But they were very difficult to meta-analyze. Scoliosis detection techniques varied. Some would take a supine X-ray, some would take a standing X-ray. The surgeries themselves were very different. The rehabilitation techniques after the surgeries were very, very different. The data was too dissimilar to aggregate and meta-analyze. But it did look like there was something there, so we continued. We restructured the study. We followed the Prisma guidelines. We included the Scopus database into the library reviewed. We did come up with a pretty good cohort. We had a total of 30 studies that were identified. We found a 19% prevalence of scoliosis during adolescence in the population that did experience infantile chest wall surgery, namely thoracotomies and sternotomies. Some people would have multiple, and the risk would increase with subsequent surgeries. This was fascinating. The prevalence of scoliosis in the general population is 1 to 4%, and this population has nearly 20. Um, Kind of looking deeper into the data, some of the more recent publications led to the inclusion of folks who are not yet skeletally mature. They may still develop scoliosis. They're still at risk. So it's very, very likely that the true prevalence is actually higher than 19. We plugged along. Okay, this is what happens all over the world. This is what happens with all sorts of surgeries. What do we see in our community? What do we see with some degree of standardization of surgical techniques, rehabilitation techniques? So what our institution switched from from paper charts to electronic medical record back in 2007. We use Citrix CHR. It does have a slicer dicer tool, so we can pull all sorts of statistics without great costs. We did some research. What are the diagnoses that lead to early infantile corrections as opposed to later on in life? We tried to standardize it as much as we could. We identified these target diagnoses as those that lead to correction in the first year of life. They tend to be fairly emergent surgeries. Later on, when we did get access to the confidential charts, we were able to confirm that in these cases, the surgeries were performed in the first year. We identified 316 cases. Of them, the prevalence of scoliosis was 8.5%. Again, double the rate of idiopathic scoliosis in the general population. Um, there's some things that we could get out of anonymized slicer data. And now the neurons are on fire. I'm like, ooh, we might have a new scoliosis subtype classification here. This is really, really fascinating. Um, we saw some really interesting trends. Um, in our adolescent idiopathic scoliosis, the sex ratio, back when I was in school, it was reported as 4 to 1 female towards male. Some of the more modern publications will report it as 10 to 1 female towards male. We saw 1 to 1. We saw exactly same split between males and females. Um, so I was like, okay, let's get a little bit more data than just anonymized statistics out of a slicer dicer. Let's go into the charts and see what we can learn. Filed for IRB approval. IRB approval was granted. The limitations to the IRB approval was we did not have access to purely psychiatry only notes. They do have a greater degree of protection as far as confidentiality goes. That would have been a different IRB process. So we got access to the charts. We went into the charts. We read thousands of pages worth of data. The beauty to the study was not a penny traded hands. It was purely time study. Some of it was done in our own time. Some of it was done in our professional time. But there were zero costs involved. There not a penny traded hands. Um, Once we went into the charts, we got to see a whole lot. These kiddos, a lot of them were described as gravely ill. One child passed away before skeletal maturity. A lot of these cases were very, very involved. They would have physical therapy, occupational therapy, behavioral health therapy, nephrology, orthopedics, pediatrics. They really had a great engagement with the healthcare system. It did make it a little bit more difficult to study. Some of these medical systems are not connected. Some of these organizations are passionate competitors and that don't like to share data. So the data was kind of fragmented and regiment and then fragmented. The other concern with it was not everybody that we performed the surgery on, we had the ability to follow up on. We are a regional academic trauma center. Ambulances will bring patients in. We do our higher order care. They go back to their community of origin. We don't know what happens to them after that. It is very, very likely that, again, the true prevalence of scoliosis in the post-surgical population is higher than our institution alone could detect. But this is what we are able to find. The post-surgical population does very much seem to experience scoliosis at a greater rate compared to the unimpacted general population in the community. These curves are at a higher risk of progression compared to adolescent idiopathic scoliosis. Approximately a quarter of the post-surgical cohort required surgery. Much lesser rates for adolescent idiopathic scoliosis that is followed up, managed, successfully addressed. Of course, if we catch it late on, when there is
And
already progression, when they're more skeletally mature, where the curves are more rigid, but on average, statistically, when everything fires on all cylinders, a quarter of our scoliosis cases do not need surgery. A quarter of these post-surgical curves did. We did see 1 to 1 male to female sex ratio, which is wildly divergent from adolescent idiopathic scoliosis. The other thing that was absolutely fascinating to notice is we saw a whole lot more of, there's a typo there, left-sided thoracic curves. Right-sided curves do tend to be towards the right. We saw a lot more left-sided thoracic curves than is typical in adolescent idiopathic scoliosis. So we really want to advocate for classifying these curves as syndromic. They're not truly neuromuscular. There's not a muscle weakness. There's not a tone issue. But there are a lot of other stuff going on that could contribute to their scoliosis risk or their scoliosis progression. One other thing that we did notice in this population is they have a whole lot of other comorbidities. We saw a lot of chromosomal abnormalities. We saw a lot of psychiatric diagnoses, a great range of ADD, ADHD, a great range of autism spectrum. There was one fascinating case that was diagnosed as PTSD specifically as a result of the surgery performed. These kiddos already have a scar. These kiddos already have some social inclusion exclusion challenges. Some of them are not able to participate in sports and activities like their peers. These kids already have some struggles. These kids already have some challenges. They really do need to be screened earlier. They need to be screened more frequently. And we really do want to advocate for engagement of behavioral health in their care. Um, you know, braces can be removed. If we were robots, it would be a much easier job, but braces can be removed. And some of our kids are very good about being non-compliant. We stick a compliance monitor into the brace and their temperature monitors. And then one of not in this cohort, but we say like, wait, how's your temperature going up? It turns out the kiddo figured out that they were being monitored and they would keep their brace next to a radiator. I'm like, wait, how can your body temperature be that high? What's going on here? Um, when you already have social exclusion, when you already have a scar, when you're already different compared to your norm, your peers, your norms, peers, having to wear a brace is a lot to ask. It makes you even more different. It makes you stand out even more. Limits your clothing options, limits how you move, how you communicate in some cases. We really want to engage with group support, with behavioral health support, things like journaling, doll braces, Higgy bears, really makes a much bigger difference for this patient population compared to some of our unimpacted general population folks. Um, it still very much looks to me like we might be dealing with a different curve subtype. And I can appreciate that a chest was cracked open, there were rotary forces applied. When we were attempting the meta-analysis, some of the authors did directly link the scarring, the adhesions, as part of healing that surgery to the scoliosis risk that was seen. But I can't prove it yet. I can't show it yet. We're a trauma center. We're not a pediatric center. We're not a cardiology center. I don't have the statistics to show it. It would be absolutely fascinating to combine the data from a number of institutions, get better statistics, and it's still very, very plausible that we are dealing with a unique curve subtype. For this time, the best data that we have available is to classify these curves as syndromic. It will tell the insurer, it will tell the orthotist to be a little bit more vigilant that these kids do need more follow-ups. They may need more braces. They may reject one in favor of one that's less biomechanically ideal, but will be worn, will be more effective. The other area of research that's really coming onto the scene in a very major way is the role of the physiotherapeutic scoliosis-specific exercise. They have been shown to mitigate the risk of scoliosis onset, scoliosis progression. How that would impact this population would be fascinating. But I'm not a physical therapist. That's not an area that I can study. It would be absolutely fascinating to get a team of researchers, a team of geeks together and take a look at this population with more statistics. That's all I had for my spiel.